Hello, my name is Angelique van der Lid. I'm from the Netherlands, and I'm a member of the Pels and Als Advisory Council of the International Alliance of ALS MND. Today, I will be presenting on the results of the fundamental rights of people living with ALS MND survey. Next slide, please. The first version of fundamental rights was conceived in the 1990s. The Pels and Als Advisory Council, PCAC, is charged with helping the board of directors of the International Alliance consider and include in its work the wide-ranging opinions and ideas of people with ALS MND and caregivers to the people with ALS MND from across the globe. And the fundamental rights are reviewed and updated annually by the PCAC. In February 2021, an independent document of the fundamental rights for caregivers is created, as their needs and rights differed from those of the person living with ALS, but also of very great importance. Next slide, please. Our aspirational statement is that these fundamental rights represent the ideal for individuals living with ALS MND and caregivers worldwide. These documents represent the set of rights of all Alliance members, organizations should adopt and promote as conditions, systems and resources allow. Next slide, please. I'll breeze through the Pels fundamental rights. As you've all seen the rights before, but people living with ALS MND have the right to the highest quality of care, treatment, information in education, and most importantly, choice. Next slide, please. They also have the right to end-of-life choices, accepting or refusing, and to provide input into their healthcare systems. They also have the right to the best quality of life possible and life without discrimination. Next slide, please. They have the right to confidentiality, privacy, and economic remuneration where possible, and last but not least, access to genetic counseling and testing. Next slide, please. The survey was based on those ideal rights, and respondents were asked to answer questions based on their experience in their countries and which regard specifically to their ALS MND experience. Key objectives of the survey were: find strengths and weakness at the global level, and be able to learn from the best and others ways to help associations and regions. Provide data from each country with the opportunity to benchmark and evaluate. Generate further questions and raise topics that require further attention and discussion at roundtables or the annual conference. Highlight the areas the Alliance can prioritize for the creation of resources to help member associations in their advocacy. provide insight for further focused surveys on specific topics to capture more granular data.
Thank you, Angelique. I am Jessica Mabe, Programs Coordinator for the International Alliance of ALS MND Associations. Data collection began with a soft launch on Thursday, 19th of August, and then was rolled out fully on Thursday, August 26th. Data collection closed in the morning of Monday, September 27th. Some key demographics are: we received responses from 32 countries. Total responses received were 1,086, which break down into 410 from PALS and 474 from CALS. 202 responses, that was just 19%, disqualified as they responded other in the initial qualifying question. The ratio of qualified responses was as expected for PALS and CALS. As the data will show, there is lots of work to do. Some low levels of agreements were expected, but concerning that other areas are still not at the standard where they should be. The data we will be sharing is focused on the global responses. In this chart, we have summarized the agreement responses for the fundamental rights of PALS. The bars colored in purple and orange are to identify the rights that had various components: purple for choice and orange for genetics. The first piece of data that stands out is that overall agreement is under 75% and the median is 45%. Healthcare and treatment have 49 and 44% agreement respectively. Very low considering they are the key pillars on the quality of life of PALS. We have a massive challenge to overcome around accessibility to treatments. We ask, what can we do to increase these figures? 59% agreed that they had access to information and education. We're not surprised by these figures. We are aware language barriers are a key factor, with the majority of information being published in English. The partaking in choices, this is our purple bar, around health and support workers, treatments, and places of care is under 50%. So we ask, what are the limitations of the country's healthcare system, access to supplemental insurance and financial capabilities? The right to accept, refuse, or discontinue treatment is the second highest in agreement in 67%. But further surveying is required to understand which is being respected, the right to accept versus refuse. The right to provide input on healthcare and support systems is very low, with 35% agreement. PALS are the ones that know what they are going through. What can we do so their experience is taken into account? 49% agreed that they live without discrimination. This data also requires further surveying. Discrimination varies and the perception is different. The level of discrimination varies in countries and regions and races. The survey did not specifically address disability rights, and we are aware that these are not being respected in many parts of the world. The right to confidentiality and privacy is high with 75%, but this data raises the question if the respondents considered newer aspects of confidentiality, like in genetic testing. The right to remuneration, benefit, and entitlements is very low, 40%. So we ask, why is this? Is it because of lack of information of what is available to them, or simply it is not available in their country? 25% agreed to have supplemental insurance. Why is this so low when this could help PALS and their families from going into poverty, as it would help covering many of the costs the ALS MND diagnosis incurs? Last but not least, our orange bars refer to the fundamental rights focused on genetics. Overall, the agreement is very low with 33%. Genetic counseling and testing are fairly new areas and still not implemented in many parts of the world. This chart provides us with a breakdown of the levels of agreement when asked if they agreed that they had access to the highest quality of care within their healthcare system. Overall, there was a 50-50 split in those who agreed versus disagreed that they had access to the highest quality healthcare. What we found is that agreement tends to be in high-income economies and disagreement in lower and middle-income economies. This figure reflects agreement on having access to highest quality treatments available within the healthcare system. Slightly more respondents disagreed about access to highest quality treatments with 53% than to highest possible healthcare, 49% in the previous slide. Also, this agreement was mostly coming from lower and middle income economies. 39% of respondents disagreed to having access to information and education. And as we all are very well aware, the key is to have access to reliable information and education accessible across the world. Here we show the level of agreement of the right to choose PALs, and PALs should be clear on the choices available to them and the right to choose. As you can see, all levels of agreement are below 50%. We notice there appear to be a gap between some nations, which makes sense when we know that some regions have more choices and access than other regions. Looking at the levels of agreement regarding remuneration and other economic benefits, the level of disagreement is higher at 53%. High-income economies are more in agreement. This also raises the question, are some remuneration benefits and entitlements available, but they are not easy to claim or find out about them? Anecdotally, we know that ALS is a disease that causes poverty. The PCAG has wanted to study economic impact of ALS MND. 63% responded that they do not have supplemental insurance, and a factor is that it can be expensive. This has raised the question, how does the lack of insurance affect the level of care and treatment received? 67% agree that they have the right to accept, refuse, and discontinue treatment. However, we do want to ask the question if refusing and discontinuing treatment is properly discussed with PALs as options. This right applies to all three cases: accept, refuse, and discontinue. Being able to provide input reflected 52% in disagreement. I touched on this on an earlier slide. Who are the ones that live with ALS MND? Who take the treatments? Who receives the care? PALs are the ones that have the knowledge and experience. We need to find a way to improve the exchange of information. This figure reflects the right to live without discrimination, and it's interesting. 51% said yes, 49% said no, and 21% unsure. Why such a large percent in unsure? Are they unclear about what discrimination towards them could be? There should be a larger yes response, but at the same time, we do wonder if those who responded yes considered all possible areas where discrimination could apply. That could be disability, genetics, racial, economic, regional, clinical trials, just to mention a few examples. With the tough laws and regulation around data protection, a 74% agreement was not surprising, but there are still gaps. Where are they? In most part of the world, genetic counseling and testing is a relatively new topic. Availability and access to all genetic related areas is still very limited and only available to certain countries. How can we make all areas of genetics in ALS and MND be available and accessible worldwide? We did a matrix analysis where we explored the relationship between the level of agreement for the highest quality of care and the highest quality treatments within certain categories. For quality of care, access to a multidisciplinary clinic who PALs receive care from, and areas in which support is received. And for treatments, we made the relationship with access to riluzole, access to edaravone, and access to clinical trials. At a global level, we can now extrapolate the drivers of highest quality of care in the following categories: receiving care from a social worker and nurse who specializes in ALS MND, and an occupational therapist, also having access to a multidisciplinary clinic, and receiving support in voice banking or at or near diagnosis. The drivers of highest quality treatments were the top three categories: were having access to clinical trials, to have participated in a clinical trial in the past, or currently participating in a clinical trial. We also want to highlight the relationship of having access to an ALS MND association that provides support with the level of agreement for the highest quality of care. We can determine that from the total of 70%, 82% agree on the positive impact of the ALS MND association on their quality of care. What do associations need to be doing to address help for PALs? This brings us back to the fundamental rights for people living with ALS MND. ALS MND associations are key in shifting these rights from aspirational to reality. the fundamental rights for people living with ALS MND should be an affirmation. So we have the survey data. So what comes next? We will be holding a webinar in the new year to discuss the data in more detail. We will dig deeper into the data, develop further surveys on particular topics, learn from the strengths and work on addressing the weak areas, identify the areas that the Alliance needs to prioritize, and we will also share country-specific data with individual associations where statistically significant. Thank you for your time.
Thank you, Angelique and Jessica, for that presentation on the fundamental rights of people living with ALS survey data. If anyone has any questions, feel free to put them in the chat, and any of us would be happy to answer them. I have a question just to get the ball rolling, and I'm going to ask both of you. Was there anything that you were surprised by in the data when you first saw it, about something that was higher than you expected or something that was lower than you expected? Angelique, do you want to go first?
I thought the question about discrimination, that was maybe we didn't explain it good, or that was a little bit funny, but at the same time it was confusing. So yeah, I think we have to dig deeper in that.
I would agree with you, and I think the results, while some of them were clear, some of them raised more questions, and
Right.
We'll look at the survey tool for next year to see if we can be clearer on areas like discrimination, to be able to explain what it is we're exactly asking. Jess, do you have something that you were surprised by?
I think overall, I was surprised about how low the level of agreements were on key areas that should be pretty much standard. So you take things like access to Riduzole and access to Edaravone and treatments overall. I thought that should be a lot higher, and that I do think we need to work further on getting that accessibility.
It really highlights accessibility as an issue that the Alliance has to work on going forward. And certainly that's a theme we're going to see in other areas of the presentations today and in the rest of the Alliance meeting as well. Jess, can you speak a little bit about the remuneration results?
Yes, the overall remuneration is very low across the board, and the key message, I think, is that I reckon in a lot of the cases it's about lack of information with regards to what is available to them. I think there are laws in place in many countries. I think there are, I'm not saying across the board, I think it will vary from country to country and region to region. But I think there is an information piece for us all to work on with regards to letting PALs know what they have access and what they could get from the government. But above that, I think there's also a larger piece for us to work at a global level with regards to remuneration. So I think there's two angles to it. One is about information and now knowing what's already available, and about what else we can make available or advocate towards making available.
We have a couple of questions that have come in the chat. The first one is from Gort-Jan Blanc in the Netherlands, and he was asking, is this the first time the survey was done, or was it done before? This is the first time the survey was done, and we did really two different surveys. One was based on the fundamental rights of people living with ALS, and one was based on the fundamental rights of caregivers. And we're going to talk about the caregivers ones later in the program. But I think this is such a foundational survey that we will be doing it again. And as Angelique said in the objectives and Jess said in the outcomes of the next steps, we might have some micro surveys that dig into specific pieces where we need to know more about why people answered the way they did. So one of the examples Jessica gave was on the end of life question, is it that they're agreeing with the right to accept or the right to refuse, because they're all in the same question. So it really depends on your jurisdiction, and it depends on which viewpoint you're answering within the question. So things like that we need to dig a little deeper into, and discrimination, as Angelique said. So this is the first time we've done this survey. We matched it exactly to the way the fundamental rights are written for people living with ALS. And we will do further surveys in the future, and the overall survey as well. Some of the other questions I'll continue to answer because they're about the survey results themselves and the survey mechanism. And Alper noted that the outcomes that we talked about today are global, and that's true. We do actually have some regional results and some country results as well, and that's why we're going to do a webinar in the new year. The format of the Alliance meeting is that we do short presentations, and in the webinar in the new year, we'll dig into some of that regional data and country-specific data. One of the shortcomings of this particular survey is we had really high responses in some countries and lower responses in other countries. So if we do this survey again, we'll do a longer lead up to it to make sure we get more responses in more countries. We did hear from 32 countries, and I believe about a dozen of them or so were statistically significant enough that we can draw results from them. And so we will definitely be doing this survey again, probably a year from now, and we'll, as I say, have a longer runway leading up so that we get more responses. So yes, we're focused on the global results today. We'll talk more about the regional results in the webinar, and then with the country-specific results, what we'll do is we'll work with our member organizations for those particular countries. So I'll use Colombia as an example because Jessica's on the line here, and Netherlands is an example because Angelique is here. So we'll sit down with ALS Patients Connected and ALS Stitching to talk about the Netherlands results, and we'll sit down with Acela to talk about Colombia's results against the global to see where there's gaps and differences that are very country specific. So those are just some summary comments about the survey instrument itself and what we're going to do with the data. Andrea asked if we're going to be posting this data on our website, and we will. We'll do it in conjunction with the webinar in the new year, so that we look at PALS fundamental rights results, CALS fundamental rights results, and those regional differences as well. Angelique and Jessica, any last comments before we move on?
Yes, we still have a question from Norman in the Q&A.
I missed that one. What was it, Angelique?
Do you think the survey participants represent those who have already access to internet and some contacts in the ALS MND community? I think it's a yes. Yeah. And he would think that those who are really isolated are not represented here. I don't think there's a solution, but we have to recognize this limitation. He's absolutely right. Yeah.
Absolutely, I agree, Angelique. And when we talk about anything in this community, even as it relates to telemedicine, you know, telemedicine only reaches those who are technologically savvy or have the training to be able to use it. And it for sure isolates a segment of the community that doesn't have that technology capability. And that's true for our survey as well. There would definitely be a pocket of our community that would be isolated from the survey instrument.
But to add to that, I just want to say a thank you to everyone that participated on the survey and sharing it with their community. I think we also bridge a huge gap by actually having the survey available in many languages. And thank you to all the member associations that helped us with the translation, because that allowed us to capture information from countries that are not English speakers. So that gave us a whole new data from different parts of the world. So thank you very much to everyone that participated.
And thank you, ladies, for working together. It was really nice.